Hi, everybody. Thanks so much for coming. Nice to see you all on a nice cold evening. So I'm Nikhil Premchand. I'm an infectious diseases consultant, but I thought we could talk a bit about infectious diseases and a little bit about digital things in the NHS. In terms of what's what, so the bits I want to cover is just, I was asked to talk a little bit about my different roles and then just a bit about a few other bits and pieces of clinical information. So I'm an infectious disease consultant. My specialist interest is what are called bone and joint infection. And in addition to that, I do some regular infection work, and by all means, feel free to ask me about any of this stuff later on. So I also do work in a specialty called acute medicine. So that's the specialty where patients are admitted through the front door acutely unwell. So I do some work in that field. And then I do some work in Cumbria on viral hepatitis. So really what I'm illustrating to you is that I have a range of different roles and how it's possible to combine those roles when you're doing a clinical job. And that's one of the facets I want to just explain to you, is that there's a range of opportunities when you work in health. And then essentially, I also do some digital work. So for my organisation, which is Northumbria Healthcare, that spans effectively from the Scottish border all the way down to Wallsend and across to Haltwhistle. I lead on the digital side of things there. So that's the those are the different roles. And then in addition, I have a training role as well for the region. So that's the bottom role there. And that's how I ended up coming to you guys tonight. But the reason in particular I want to talk a bit about infectious diseases is that this week is World Antibiotic Awareness Week. So just a quick show of hands, was anybody aware of that at all? Anybody? Yeah, so in the room, there's nobody that has heard of that. And essentially, this is a WHO, World Health Organization initiative that's been going. So one person online, there's two people online have heard of it, but it's a WHO initiative in terms of antibiotics and reducing antibiotic abuse. And I will hopefully, by the end of the next half an hour, 40 minutes, explain to you why that's important. So that's one of the reasons I wanted to talk about infection today. So a bit about the clinical work that I do. So this is a graph looking at life expectancy from 1850 to 2021. And as you can see, there's a significant increase in that period of time. So now I want you guys to think about what you think has been important in terms of making that change. So what do you think has improved life expectancy in that 171-year period? So you saw that rapid increase. Okay. So the answers that I'm seeing on the screen and what you guys are putting in are typical things that people say first of all, but actually you're wrong. And for the people that are answering now, you've got a bit of a clue from me that I think that what's on the screen may not be right, but So what you're putting down is a lot of medical things. And actually, the reason that life expectancy principally has increased is nothing to do with health. It's mainly to do with basic things like sanitation, clean water, and nutrition. Okay, so they're really important things. So don't forget, in general, healthcare is about simple things done well. And so all of the stuff that you've got on the screen there in terms of better healthcare, vaccinations, better medicines, that's all quite highfalutin stuff. So it's a bit like baking a cake. The cake is your clean water, nutrition, sanitation, and the icing on the cake is the healthcare piece. So don't forget that. That's a really important point. So we're going to take a bit of a pause from Menti now, if I can hopefully get back. Here we go. Yeah, so we can get back. So I just want to quickly show you, we're going to go through the next few slides fairly quickly, but just to give you an idea of what children die from and then what adults die from, just so you can see. So this is in 2019, what types of things kids die from. So you can see that infection is the #1 thing globally. So infection for children, and there's a number of different infections that you can see down the chart on the left-hand side. So things like malaria, neonatal sepsis, meningitis, whooping cough. There's loads of infections that are causes of death for children. So that's an important point there. And then in terms of adults, so adults are no longer dying of infections. So if you survive your childhood years, and it's things like cardiovascular disease, cancers, car accidents, okay? And so just look at that. Then HIV/AIDS comes into there as #4 globally in 2019. I'll talk a bit more about HIV/AIDS shortly. And then just to look in less developed countries, so low and middle income countries, what you can see is that there's other infections that creep in there. So the basic things I was talking about that may not exist as effectively in low and middle income countries are still causing problems. So things like tuberculosis, nutritional deficiencies, malaria is there as well, diarrheal diseases. So the point I'm making is that basic things like sanitation, nutrition, and water are really important in terms of causes of people dying. So now we come on to some of the stuff that you're putting up in terms of your answers. So this is smallpox cases from 1920 to 2010, and there's a rapid, dramatic change from the 80s onwards. So what do you think? Just shout out, because I haven't got a mental slide for this one, but just shout out what you think the reason for this is. Why does this disappear? Say again? Yeah, vaccination, exactly. So this is the impact of vaccination. So remember, the vaccination is a relatively recent phenomenon. And so when we talk about vaccines, in a very, very busy slides, in the blue, you've got all the vaccinations, and in the orange, you've got the vaccinations, and in the blue, you've got antibiotics. So we've had antibiotics for roughly 100 years now. We've had vaccines for, again, about 200-300 years now. So really, vaccination is a latecomer to the party, and antibiotics are an even later comer to that party. And it's what's important to remember is that vaccines have been incredibly important, probably for the last century, but see other bits and pieces before then. And also, importantly, we can now vaccinate for things other than infections. So you will all probably have been vaccinated for HPV, and that is a vaccine against cancer. So vaccination and stimulating the immune system is really important in terms of preserving and maintaining health. So this is something that Liam Donaldson, who used to be the chief medical officer back in 2002, he's now one of the clinical leads. He's effectively the medical lead for our region because he's from the Northeast originally. But he said back in 2002, infectious disease is recognized in international boundaries. So newly emergent infection in one part of the world must be assessed as a potential threat to this country. This is 2002, so 17 years before we had the big COVID pandemic. And so really important that this is something that's been an ongoing and challenging field prior to COVID that people know about. And I thought I'd give you a quick example. So I'm going to go through the next few slides fairly quickly, but I just want to illustrate to you why infectious diseases, in my opinion, and hopefully yours by the end of the evening, is the most important specialty. So this is about a condition called MERS-CoV, so Middle Eastern Respiratory Syndrome coronavirus. Now, you don't need to know anything about that as far as in terms of what's what. You just need to think about the principles. And so what this is about is a condition that it's a viral illness, just like COVID. It's the same family as COVID, and it causes respiratory symptoms as well. And patients get quite sick, and some of them unfortunately die. So I'm just going to rattle through some of the technical bits about the virus. So this is essentially a virus that causes fever, cough, diarrhea. It has what we call a relatively short incubation period of 5 days on average. So that's the time it takes from when you're infected to when you get symptoms. And it was initially found in the Middle East. So that's your starting point. It's a viral infection from the Middle East with a relatively short incubation period. Now, what I want to talk a bit more about is the importance of the infectious disease and thinking about that. And what we'll talk about is an outbreak in South Korea in May 2015. So firstly, don't kiss your camel, okay, because you can get infected from your camel. And this is something, the camels may live in quite close proximity to humans in parts of the Middle East. This is what it causes for patients. Your lungs get filled with fluids. These are a series of 4 chest x-rays. Normally, your lungs are full of air, so they're black. And you can see all the white bits. That's either inflammation or infection or fluid. That's what's making the x-ray go white. Now, this is how this infection spread. So it went from camel to camel, then camel to human, and then from human to human. So they're the principles that I want you to think about. So remembering, we're going to talk about this May 2015 outbreak in South Korea. That is the bit in red. So it's been going on in Saudi Arabia and other countries for a number of years before, and then in 2015, we have this outbreak in Korea. And why did that happen? So a businessman went on a business trip to Saudi Arabia. He returns to South Korea, and within 7 days, he gets symptoms. And what happens at H1, 2, 3, and 4 that you can see on the screen are 4 different hospitals that this patient goes to. And what you can then see is that because people don't think of this, you effectively have an explosion of infection that spreads throughout these hospitals, affecting not only healthcare workers, affecting and infecting other patients, infecting and affecting visitors as well. And unfortunately, as I'll show you in a couple of slides, I think it's about 80 people die from this. So it's a significant outbreak because people don't think that to ask, has he traveled abroad? So this is looking slightly differently. The size of the bubbles, the number of cases that are affected. But what you can see is on the left-hand side, from the turquoise, you have the primary case. And he then goes to these different hospitals seeking opinion because he's not getting better and he wants to know what else he could try. And this then spreads to infect multiple people. The consequence of this, sorry, it's 36 people die. So the consequence is there's 186 people who are infected. Of them, 36 people die. And so this is because we're not thinking about infection. And this is how easily an infection can spread from one country to another if we don't think about it. And that is why infectious diseases can cause the havoc that we've seen with COVID, but also that we see with other conditions. And that's why, for me, infectious diseases is really important. So that's your starter for 5. So then moving on to think about antimicrobial resistance. So we have an increasing problem with multi-drug resistant bacteria. And as a result of that, we're going to end up with infections that we cannot treat. And that results in more deaths. And that's a big, big problem. And the next few slides, this is looking at data from Europe. And what I want to quickly show you is if you just look at where we start with green, just look at what happens to the green. This is year by year, looking at the resistant bacteria of a particular class. So just looking as we go, see how the green disappears and you get more red, more orange, and effectively the situation gets worse and worse and worse. So now then, just to go back to Menti if I can. So just a quick one. So what proportion of patients admitted acutely to hospital in England do you think are treated with antibiotics? So this is all patients in England. What proportion do you think get antibiotics? You're all pessimists. So we've got two groups of people. So there's probably a group of people saying about 60, 70%. And that's high. So remember, these are all the people being admitted to hospital. And on the left-hand side, you've got another peak around about 40%. Okay, so the true answer, let's see if this, yeah, the true answer is about 30%. So it's roughly a third of patients who are admitted to hospital. Okay, so it's just something to bear in mind, but that's still a lot of people. So at any one time, 1 in 3 people in hospital in England are on antibiotics. And in England, in any given year, 1 in 3 people takes the course of antibiotics. So these are drugs that we use lots and lots and lots of. And the problem is, it's a phenomenon that occurs around the world. And what you can see here is that if you look at that green line, you can see going up and up and up through essentially from 2005, 2006 onwards, all the way to 2015. And what you get is you end up with antibiotic-resistant bacteria. And the problem is, and as I'm going back to what I was saying at the very beginning, the important things here are about good basic sanitation, water, nutrition. If you don't do these things that we call public health, and you try and use antibiotics as a surrogate, you end up with increasing resistance, and that's a huge problem. So how does antibiotic resistance occurs? Because the bacteria replicate much more quickly than humans do, and therefore, the bugs are error prone in their replication, so they can make mutations that are resistant to the antibiotics, and these resistant bugs then spread into the food chain, spread into the water chain, and the whole cycle goes round and round and round, and then patients become colonized where the bacteria sit on their skin, and that then results in the antibiotic resistant bugs being in the system and being on people. And then if you have an operation or something like that, where the skin is cut, that can then lead to the antibiotic resistant bacteria causing problems. Now remember that all of us are covered in bugs from head to toe. It's estimated that about between 1% and 3% of your total body weight is bacteria. Okay, so you're all covered in them. You're teeming in bacteria. Certain places more than others, like your scalp, like the moist areas of your body, there's far more bacteria there. But we are all covered in bacteria, and that is how this then causes problems. And just to give you some idea of scale and what's going to happen. So when they look back in 2014, or look forward from 2014 to 2050, the estimate was that by 2050, there would be more deaths due to antimicrobial resistance than causes like cancer. So remember what I showed you on the second or third slide in terms of causes of death. Cancer was right up there. So by 2050, infections are going to go right back round. So that cycle where we improve things with better sanitation, clean water and nutrition, we are now blowing that up. This is the problem that we're going to have, is that this is going to come back around to bite us. So what do we do about that? Well, really, it's about being careful about when we use antibiotics, using them carefully, using the most narrow spectrum antibiotic for the shortest duration that we can. And that's something that all of us have a responsibility for, because it's your generation that will be dealing with this, for those of you that become doctors in due course. I'm going to take a slight segue just to tell you a bit more about other infectious diseases, just to give you a bit of a broad idea of what we do clinically. So a couple of words about HIV. So globally, there's about 40 million people that live with HIV now. So this is a global problem. HIV is now a completely treatable condition. It's not curable, but a completely treatable condition. And now I think there should be, yeah. So in some parts of the world, the prevalence, so the number of people living with HIV is up to as many as 1 in 4. So just think that the room, there's probably about 50, 60 of you in the room. So 15 people would be living with HIV. So it's quite normal in some countries for everybody to know somebody that lives with HIV. And that has a big impact on society as a whole, but it's something to bear in mind. Now, I've been talking for roughly 20 minutes or so. So let's quickly see what you think. So in those 20 minutes, how many people do you think have been infected with HIV globally? So 20 minutes. Remembering there's 40 million people that live with HIV. We've got a good range of guesses, and it's very clear they're guesses because we've got a big spread of different figures, which is absolutely fine. I'm not, but it's just to give you in a second to give you an idea of what this means. Okay, so the right answer is 50. So it's about 2.5 people every minute. All right, so that's the so remembering of those, there's a large number of children being infected. That's either being infected when they're being born from mother to child transmission, or through being infected through sexual activity as a child. Now, importantly, in 2023, there's still 76,000 children globally under the age of 15 dying of HIV/AIDS. This is a treatable condition. And in 2023, 76,000 children died. So just bear that in mind, okay? So these are treatable conditions. And that's why, again, as I said at the beginning, infectious diseases are really important. In terms of treatment, we started out with very, very complicated treatment regimes, people taking handfuls of tablets every day. We're right down to taking one tablet a day. And we also have injectable agents that you can be injected with every 2 months. So really, treatment has really moved on. And so what we know is that if you take treatment, you cannot spread HIV, you cannot transmit HIV. So if you have a controlled infection, your viral load is less than 200, you cannot spread HIV to anybody else. And that's really important, because if we treated patients, we wouldn't have that many more infections and we wouldn't have these deaths. And so that's why it's really, really important that we can deliver healthcare across the world. Moving on briefly, just to illustrate the scale of other infections. So hepatitis B, there's about 300 million people that live with hepatitis B globally. So that's about 5 times the population of the UK. And then hepatitis C, so again, there's roughly, I think it's about 20 million people that live with hepatitis C now, but there's hotspots of hepatitis C. So these are all viruses that can spread through blood and body fluids. And essentially, the problem is with hepatitis B and hepatitis C, these are viruses that sit in the liver and they last for a while, but they cause problems downstream like liver scarring, liver cancers, and people then die of liver failure. And so hepatitis C is a completely treatable condition now. So we've gone from not having any treatments at all for hepatitis C when I started in this game about 25 years ago, to now this being a completely treatable condition with tablets for between 8 and 12 weeks. So that's just a brief segue through the different range of infectious diseases to give you a flavor for a bit of public health information, to give you a bit of a flavor about tropical infections and how infections can spread in healthcare settings. And now I'm just going to move on to talk a little bit about digital health, because that was the original remit that I had when I was given the slot to talk to you. So what is digital health? Well, it's about using digital technology to improve health and social care. So I'd be interested to know from you guys, there's 3 questions on here, and just to get your opinions on digital. So are you comfortable that your health record is digital? Firstly. Secondly, are you happy that your doctor uses a computer during a consultation? And then thirdly, what do you think about artificial intelligence? And what do you think about artificial intelligence being used to make a diagnosis? And there's no right answers, no wrong answers, just to get an idea of your confidence and your comfort zone in terms of what you think. So on the right-hand side, it's strongly agree. On the left-hand side, it's strongly disagree. I just want a quick show of hands for the people in the room as a subsidiary question. And that's how many of you have used generative AI, so things like ChatGPT and other platforms like that. Okay, so interesting. So people are quite comfortable that the doctor uses a computer during the consultation. There's some people that are less comfortable that their health record is digital. But in terms of artificial intelligence, where the jury's still out and people are much less comfortable, and that's interesting to see where people sit with that perspective. I'll leave that to continue to collect the votes and go back to the talk. So what we're going to see is that digital is going to become more and more important in healthcare over the next probably 5 years. It's important now in my perspective, but I work in that area, but it is going to become increasingly important. And the reasons why I will come to in a second. But essentially, digital and digital change, like in any field, is about taking the people along with you. So when you're trying to change how people work, and how you'll have seen this in areas of work that you guys do in terms of teamwork and group work, but how you change things is about getting people to adopt that change. And that is the single biggest challenge. So the NHS is Europe's biggest employer. and trying to get people to change and to morph and to work in a standardized way, or to work at least as teams in a standardized fashion, can be really, really challenging. And so that is why there will be a big push in digital in years to come. So it's not about replacing old ways and working, it's about how we approach problems. And that's the challenge. And essentially, people feel very challenged when we talk about digitization. They feel very challenged by things like AI, as I demonstrated to you in the earlier slide, when the rating for other things was between 4 and 4.3, and your rating for AI was down at 2.2. But essentially, we need to make sure people have confidence in what we do, and that's the patients, that's the staff, and that's other users of services, to make sure that we take people on the journey with us. That is the challenge for working in digital. So in terms of what we need to think about when we're going to digital and thinking about what we do and why we do things, we need to think about what is the problem we're trying to fix. And then the other mistake that we fall into time and time again is replicating and duplicating existing systems and tools. And so you will hear about digital in the NHS, it gets a very bad name because there have been lots of millions of pounds spent on digital innovations where things have not been effective. That spend hasn't been great. And so there's a real spotlight in terms of looking at digital and looking at how we work and how we could work more effectively, more efficiently, but doing that sensibly. And that's the real challenge. So for a couple of minutes, I think I've got a few minutes left. So I just want to spend about 5 minutes going through. These are some slides from one of my colleagues that can't be here this evening. But this is to illustrate to you how complex and complicated healthcare is. And then hopefully I'll be able to show you a video in a second about what we do in our region for that. So this is a patient called Amy. Very, very busy slides. I'll just read out a few key points. So she's 68, she lives alone, she's got 2 daughters locally, diagnosed with lung cancer, and essentially since diagnosis she's become visually impaired and very restricted by that, needs somebody with her all the time. Offered treatment with chemotherapy, treatment was then stopped and then referred to other teams to support her. So palliative care team, district nurses, GP. Daughters support her. She has a number of different adaptations at home. There's a stair lift, some community alarms, and there's input and support from other teams as well. Now, Amy gets sick. And one member of the team is called on the Sunday and contacts the on-call GP, who then contacts other services to help get the patient to hospital, remembering that she's blind, remembering that she has a range of different needs in terms of her frailty, and people don't always understand or know what's going on. And so now she's at home and there's lots of other people involved in her care. Now, so you can see this is a fairly complicated situation. However, this is a situation we see every single day in hospital. So this is not an unusual situation that you have people who have many different, one or two problems, but many different people involved in their care. And so what I want you to think about is how many different people are involved in Amy's care. All right, so you've got the family, and then you've got all of the other different teams that I've mentioned there before. And just think about what information, if Amy was your sister, your mother, your grandmother, what information do you think would be helpful for other people to know? Firstly, and secondly, remembering that on a weekend she's admitted to hospital, and how are the teams going to find out information about Amy? So that's the task to think about for a second. And in what I'll do is I'm going to show you, just for this individual patient, how many different people were involved. So there you go. So it's many hundred, well, it's not many hundred people, but it's well over 100 people that are involved in looking after her and in terms of trying to support Amy to get her home again. And so the challenge is to get information to all of these different stakeholders and the different teams. We have to do that digitally, because some people will be working in the community in West Northumberland, some people will be in the hospital, they'll be in different organizations, and we need to be able to share the information to help keep Amy safe. And that is where we need to be able to do this digitally. And what I want to quickly show you, I think time allows for it, I'm going to show you a quick video about what we do in our region. So yeah, these are other people involved in care as well. So a range of different people, from community matrons, patient transport, etc., etc., etc. They're all involved in keeping Amy safe at home. But basically there's something in our region called the Great North Care Record. And what the Great North Care Record is a system that we have to share information widely through the region, so that all of the different people involved in people's care can look at information about you. And so what we do is we securely share information about patients, say Amy, for instance, about the information, the medications that they're on, who looks after them, who's involved in their care, so that when I'm seeing a patient in hospital, I can look at that and see what the GP's been doing. I can look and see what the palliative care nurses have been doing. And by using digital tools, what we can do is we can make that information firstly shareable, secondly, keep the patient safe, and thirdly, use that information to help plan services going forwards. And so that, if you get time later, just Google the Great North Care Record. You can find the video on they've got a YouTube channel as well. But essentially what you can do is you can see how the Great North Care Record works, but also how it helps us look after patients. And what we find is that this is one of the most effective ways of being able to share information. So by sharing that information, what we can do is we can then make it easy to keep patients safe, to keep patients in their own homes, which is where they want to be, and to offer them the best care possible. And that is why digitization of records and sharing of information is so very important, to give patients the care that they want and that they need. So just in terms of digital, a couple of other bits and pieces. So we've been using digital tools for roughly 60 years now. So, but essentially we have in the Northeast, North Cumbria, we have about 950,000 views of the Great North Care Record now every single month. So for pregnant ladies, their information is held in the Great North Care Record, so the community midwife can see that information, and that can then be seen when they go to hospital, or if they go to a different organisation, that information can be seen to try and keep patients safe wherever they are, be that in the community, be that at home, be that in the hospital. And so that's what we call a local health and care record. And essentially, we are one of the leading areas in terms of using these local shared records in England and Wales. And so that's certainly something that we're very proud of in the region. So I just want to finish off from the digital point of view, because I know that some of you may not have been coming from the medical school side of things, but just from the digital side of things, and just to illustrate to you that this is more than just clinicians, okay? So from the digital point of view, there's a range of different stakeholders involved in the team. And so if you think about this in terms of a game of football, and these are some slides my colleague Graham Evans has kindly lent me, but essentially you're trying to get the goals, all right? So you're trying to move the patients forwards and help the patients get where they want to be. And so you have a range of different teams involved. And it's just to give you an idea of how complicated healthcare is, and how complicated and how many different numbers of players are involved in the team. So you've got the frontline teams, the clinicians that you'll be familiar with, but then there's other teams that you may not be so familiar with. So there's social care workers, there's allied healthcare professionals. I think a couple of weeks ago you heard from another allied healthcare professional, I think one of the dietitians presented from what I saw on YouTube, and they're a really big and important group of staff as well. The groups of people you won't be familiar with, and this just to illustrate the range of different roles you have within health service. But so you have people who are digital leaders, people who are trying to help the workforce with that transformation project I was telling you about before. So digital midwives, digital information officers, there's a whole bunch of people that aren't clinical working in digital, and also a bunch of clinicians like me who work in digital to make sure that what the clinicians need and their needs are dealt with. But to underpin that team and to keep everybody and the show on the road, we have a bunch of staff that work in digital within the NHS. The NHS, as I said before, is the biggest employer in Europe. But from a technology point of view, the NHS is a big, big employer in terms of technical staff and people that software developers, software analysts, but then importantly also from the data side of things, because the information that we collect and all of the data that we collect from these tools that we can use to improve services needs to be analysed. And so just remember that there's a range of different opportunities and a range of different professions within health that aren't specifically to do with health, but that health absolutely relies on. And that is why this is a team sport. And it's really, really important that we always remember that. So just to finish off on the digital side of things, just to really think about what are we trying to do? And so what we need to do is to think about problems. So what are the problems we're trying to fix? We need to work with the stakeholders, work with the patients to fix the problems. And really important, what we try and do in our region is to stop reinventing the wheel. So, you know, our belief in the region is that the UK is probably the world expert in reinventing the wheel, and we just need to get on and do some of this stuff. And so it's just really important that we work as teams and that we work forwards like that. So that's what I was going to say from the digital side of things. Now, if we've got a couple of minutes, are we all right for a couple of minutes? So I just want to take you through a few different areas that might be interesting or useful for you in terms of interview fodder, is what I've called it. So the first thing is, so this is a report by somebody called Aradazi. So just a quick show of hands, has anybody heard of this report? It was published in September. Yeah, so a couple of people have. So basically the Darzi report, so Aradazi is a surgeon who issued a report about 14 years ago, his previous report. And he was then asked by the government when they came in to investigate the NHS and see where the NHS is going. And on the right-hand side, you've got some headline news. So the NHS is in serious trouble. The health of the nation has got worse, and that is putting significant pressure on the health service. And that then means that access to services is very challenging. And so what you may hear about, what you may see on the news, is people talking about that they can't get appointments in primary care, they wait in A&E for hours and hours on end, and that it's very, very challenging. And that is true. So it's variable through the country. So where I work in Northumbria, we're lucky. We perform fairly well in terms of A&E, but it is still, in other parts of the country, it's very, very challenging. And you will see big queues in A&E, ambulance queues waiting to drop off patients. And that's a universal problem now. So what do we need to do about this? Well, the first thing is that more care needs to be delivered in the community. And just to give you some idea of scale, at the moment, 90% of work is done in the community. So 10% is done in hospital, but very much the minority, but the money's the other way around. So about 90% of the money is spent on hospital and hospital services, whereas 10% of the money is spent in the community. So that needs to pivot. The second thing, and one of the reasons I want to talk about digital, is that we need to become more productive. And there's what Aradazi describes as a tilt towards technology. And that is why digital will be increasingly important in your clinical lifespans. And then finally, we need to keep our staff engaged and keep our staff really working towards this goal of trying to make our patients and improve patients' health. So that's the first interview fodder piece I've given you. The second one is about healthcare inequalities. Okay, and there's something, healthcare inequalities is a very topical theme in the NHS at the moment. Inequality is clearly a bad thing, but there's certain groups of patients who do particularly badly. So there's areas of the country where you have more deprived populations, but then there's patients that have particular conditions down the bottom of that slide. So pregnant women from Black, Asian, minority ethnic groups, patients with severe mental illness, those with chronic respiratory conditions, those with cancer, and those with high blood pressure, all underpinned by smoking cessation as well across those groups. And so why is that important? Well, essentially, inequality is a major problem. In our regions, the Northeast North Cumbria is one of the worst in England. Any idea, just shout out for me, do you know any idea what the literacy rate is? What's the average reading age in England? Yeah, so 9 to 11 is the average reading age. So just remember that most people have the reading age of a 9 to 11-year-old, okay? And that's really important in terms of inequality. And the reason for that is that if you're disenfranchised, if you live in an area where you have poor, if it's deprived area, then your health outcomes are much worse. You live much shorter lives. You have high rates of obesity. Obesity is associated with diabetes. Diabetes is associated with infections. And so the whole cycle goes round again when you have a population that's becoming more and more unhealthy. And so that is why public health is important, because if you can prevent these problems, as I showed you at the very beginning, that you can then reduce the inequality side of things as well. The final piece of interview fodder I want to leave you with is something called the long-term workforce plan. And so this is something that was released last year. So it's an overarching plan for healthcare, the workforce overall. The three main comments that they say is train, retain, and reform. There's an increasing need for people to be generalists. So there's a need for people to have a broad palette of skills to look after our aging population. The other thing that may come up in interviews, and it may be something that's topical or something you might hear about in the news, is controversies about non-medical staff doing traditional medical roles. And so you have cohorts who are called physician associates and anesthesia associates. And if you watch the news just yesterday, Wes Streeting, the Secretary of State for Health, announced there'll be a review into that. So these are areas just to be aware of, areas that are topical at the moment, just thinking about what might be happening in health. And the other bit just to touch on is that obviously over the last 18 months, we've had significant problems with medical workforce strikes, and it's something just to think about. And as you can see on there, you know, it's going to cost money. To solve the strikes and to settle the strikes has cost a lot of money. And as I've shown you before, money is a significant issue in terms of all of the other things we need to deliver. So I'll finish there.